Welcome everyone to Pediatric Renal Nutrition Academy's first live webinar. My name is Elisaveta Johnson. I'm a registered dietitian on the clinical affairs team with VitaFlow USA. We are thrilled to have the opportunity to introduce today's speakers who are leading experts in pediatric renal nutrition and assist with the webinar entitled Pediatric Renal Transplant Nutrition Care. Please note this program is being recorded. You can access the PDFs of the handouts in the handout section in the control panel to your right. Financial support for this presentation was provided by VitaFlow USA, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. This educational program offers one continuing education credit for dietitians. You can download your certificate towards the end of the program from the handout section in the control panel to your right. Please note that questions will be addressed following the presentation. You may submit text questions into the question pane of the control panel at any time during the program. As with any CE program, questions relating to product will not be addressed. Feel free to contact your VitaFlow representative for further product information following the program. I'm pleased to introduce today's speakers. Our keynote speaker is Christina Nelms. Christina is a seasoned dietitian with over 15 years of experience in pediatrics, primarily working with renal patients. She's held several clinical positions, most notably at Children's Mercy Hospital and clinics in Kansas City. She was a certified specialist in pediatrics for 10 years and a certified nutrition support clinician for 5 years. She has been involved with speaking and educating at local, regional, national, and international professional renal meetings, including the US, Canada, Japan, and the UK. She is the lead author on book chapters in the Aspen Pediatric Nutrition Support Core Curriculum and Nutrition and Kidney Disease. An educator at heart, Christina teaches graduate and undergraduate nutrition courses through the University of Nebraska Systems, trains dietitians new to the pediatric nutrition field, and is working with us, VitaFlow USA, to create education events and materials to aid pediatric renal dietitians. Our guest speaker today is Leah Oladitan. Leah is also an experienced dietitian with over 8 years of clinical practice in pediatrics and is a certified specialist in pediatrics. She has been at Children's Mercy Hospitals and clinics in Kansas City since 2009 and has held the position of Senior Clinical Nutrition Specialist. At the present time, she is the Nutrition Services Manager. Leah enjoys research and has a handful of publications. Her clinical and research interests are in nutrition for pediatric chronic kidney disease, dialysis, and kidney transplant. Welcome, Christina and Leah.
Thank you for the introduction, Elisaveta. There may be just a bit of a delay as we transition the slides here, but I wanted to welcome everyone to the presentation. This is the objective slide, and I'm actually going to just let you guys look at that on your own, because the slide that I really want to jump to is this slide, which I think actually outlines our objectives a little bit better today. I attended earlier this month the NATCO Nutrition Transplant meeting, and at the end of the meeting they gave us a paper that actually is still in press, so this is really hot off the press information that provides a framework for the CMS guidelines execution and what a pediatric transplant dietitian really needs to know and to be able to do. And the first 4 competencies I've outlined here are the MNT specific ones. And I'm very pleased to share that our webinar today is going to be discussing short and long-term transplant outcomes, micro and macronutrient needs for candidates and recipients, food and drug interactions, as well as food safety. And then my last bullet here talks about the additional competencies that are discussed in the paper, and we are certainly discussing pre, post, and transplant phase as well, and living donation. And our guest speaker, Leah, is very well versed in CMS guidelines as she is working with her facility to expand their transplant program. So I'm excited to see what CMS information she's going to be sharing at the end of this presentation. But I would encourage you all to look out this this paper to maybe have it as part of your file at your facility, because this will likely become not only what dietitians can reference as a framework for knowing what they need to know for transplant competency, but likely also what CMS will be referring to in their evaluations. So jumping right into preparation for kidney transplant, this is especially for those of you who work with dialysis patients or CKD patients. And first of all, we know that weight management is very important. Adult literature tells us that not only is doing a transplant more technically difficult when you're trying to cut through layers of tissue, but there's also some additional risks. And although these aren't totally known, we think this may have to do with the higher levels of immunosuppressive drugs needed to regulate a kidney transplant, some hormonal imbalance, some hyperfiltration. Leptin increases proteinuria, for example. However, we're learning that these risks still apply to the pediatric patients. We have NAPRTX data of over 6,000 children that don't have quite as startling statistics as the adult literature, but still a concern that children ages 6 to 12 had higher risk of death. Adolescents had more graft failure, and there's more acute rejection in all age populations than non-obese patients. Now, that being said, I don't feel that we need to encourage these patients to rapidly lose weight, as we know that weight regain is a major issue after transplant, and that possibly just some slow weight loss will even improve outcomes, and certainly teaching lifestyle changes are a big deal. Now, being underweight, of course, is a concern, as well as we're not providing adequate nutritional source for healing. So we need to do our best to get our patients to an ideal weight. I know easier said than done. Now, laboratory management, I think everyone's aware that high or low potassium level could potentially postpone a transplant, which could be costly in case of a living donor transplant, and can certainly be a concern with somebody who's on the list that may have to pass up a kidney. So certainly controlling potassium level, but I think that there's a mindset with kiddos that have high phosphorus levels that, oh, we just need them to get to transplant, this won't be an issue anymore. But what we're learning is that phosphorus is a player after transplant, and some research in both in adults and pediatrics indicates that having a high FGF23 level, which is currently mostly done just in the research setting, isn't done clinically, but it's a good indicator where phosphorus and PTH have short half-lives, that this FGF23 level being elevated before transplant is associated with poor outcomes after transplant. In fact, a 50% decline in GFR within 2 years with having an elevated level. So although PTH and phosphorus aren't as specific, certainly trending them over time gives us a picture of our patients' phosphorus control. And so that's another reason to encourage our patients to get this under control, even if they can just hang on until transplant. Additionally, the research tells us that having poor vitamin D status may impact transplant outcomes. And so certainly making sure our patients are on calcitriol before transplant or some variation thereof, as well as often after transplant, low 125 levels were associated with greater mortality and graft loss. And then our patients and families should have education on expectations periodically before transplant. Certainly at the initial transplant meeting, but then quarterly or whatnot, we should plan to review these guidelines. I think many people think that a transplant is a magic cure, and we know that a low sodium diet certainly hangs on, and sometimes, especially because of drug interactions, some of the diet changes may be new and different, but they're not necessarily more difficult. So nutrition immediately post-transplant for our patients who are typically on the ICU, certainly we want to start nutrition and especially fluids as soon as possible. And many of our patients have a delay in their kidney function starting, especially those who have received a deceased donor transplant or those who may have been obese prior to transplant. Now, some kids, especially those who've received living donors, can move right into a regular diet when their diet is advanced. And many of the drugs actually cause some nausea and vomiting or desire to not eat. And so we really need to encourage intake, especially protein intake. The guidelines immediately post-transplant are DRI calories, but 100 to 25 to 150% of the DRI for protein, because we have to remember this is a major abdominal surgery they just went through, and they certainly need adequate nutrition for healing. And in fact, many of our patients aren't able to go home until they're able to eat enough that they can show that they can have a bowel movement and fluid, because that is critical to the maintenance of that kidney transplant. They have to demonstrate that they're able to do that. Nutrition restrictions are typically the tightest in that first 3 to 6 months post-transplant, and that is primarily because of medications. There's a need for tighter sugar or simple carbohydrate intake because many of the medications drive up blood sugar levels. Even if our patients aren't diabetic, it's, we don't want that new kidney dumping out a bunch of sugar. Potassium is often elevated because of transplant medications, and 80% of our patients have high blood pressure after transplant. So we need to make sure that they are controlling their sodium well, and because of medication affects magnesium wasting, they may need phosphorus and magnesium supplementation. So next we're going to talk about nutrition for the kidney donor, and it's always a conundrum in the pediatric world because often our nephrectomies for the kidney donors are done by an adult-focused surgeon, and at my facility this was done at our children's hospital. Sometimes it's done off-site, but the question is who actually educates those kidney donors. And I always think, to be on the safe side, even on the pediatric side, we need to at least assume that perhaps we need to do this. Now, there is not great data about kidney donors. We know that these kidney donors do have a slightly higher risk of eventually developing end stage, but the percentages are very minute compared to the general population. Because these people tend to be healthier, the risk is actually lower. But if you compare apples to apples with healthy donors, the risk is slightly higher, but again, pretty insignificant numbers. But regardless, we want to prevent any undesirable future outcomes for kidney donors. Many centers have BMI guidelines, and even within those BMI guidelines, if someone is on the borderline, we have to look at things like risks for future diabetes, anything that would cause kidney compromise. So certainly we want our patients, our donors, going into transplant with a healthy weight and with discussion about how to avoid weight gain. They need to limit sodium intake to 2,000 milligrams, ideally, again, just to hopefully alleviate potential risks for hypertension. Moderate protein intake is encouraged. Again, not great data on how much that solitary healthy kidney can handle, but it makes sense that our patients not take protein supplements, not pursue a very high protein diet. Cholesterol is also encouraged to hopefully modulate cholesterol levels. And then fluid intake of what really everybody should be doing, 7 to 8 ounce glasses. Now, some of our kidney donors who weigh a little bit more, even if they have a normal BMI, let's say they're a taller person, they may need a little more fluid intake. And although there's no need to necessarily avoid, we know that caffeine and alcohol have dehydrating effects. So it just makes sense for us to be advising kidney donors to limit those. A healthy diet is encouraged, and just kind of as a general backup policy, if the diet is less than optimal for nutrient intake, a general multivitamin may be appropriate. Let's talk about our transplant population, post-transplant, more in the long term specifically now. And what I'm going to talk about is actually a lot of general healthful diet guidelines, which we all should be doing, but they're just a little bit more important for our transplant patients. So EER for calorie intake, And our families really need to know what that looks like and what portion size is like, because weight gain is incredibly common post-transplant, which we'll talk about more in a bit. And we think that the reason for this is possibly some medications, but probably primarily because their appetite and taste has improved so much. Some forbidden foods are back, and there may be a lot of psychological influence. Macronutrient intake is recommended just at the acceptable macronutrient distribution range, just like for everybody else, with an emphasis on healthy fats and carbohydrates, limiting simple sugars, promoting whole grains, etc. Avoiding excess protein. Again, we don't have great data on exactly what that number should be, probably DRI, but most of us get a little more than DRI. And so again, we try to encourage patients not to take protein supplements, not to eat 12-ounce steaks when they're eating their meals, ideally. Sometimes I've had teenage boys who want to do some bodybuilding, and then we sometimes have to compromise, but we want to avoid excess. And then micronutrients to DRI, and again, if the patient eats a general healthy diet, they should be reaching this, but we all know that sometimes kids are picky and don't eat optimally, so a multivitamin may be beneficial. Now, the one micronutrient of note is iron. We know that that kidney is still compromised, and so some of our patients may need epogen and hence iron, especially as that kidney function declines. Now, to discuss a little bit more about this diet, some specifics, fruits, vegetables, and whole grains are encouraged, and certainly the MyPlate guideline of a half of our plate being fruits and vegetables, or at least a minimum of 5 servings a day of fruits and vegetables. I'm always shooting for more. Give me 7 a day, 9 a day, whatnot. More is better, because we know that we want these patients to have a good amount of antioxidants. We do know that our patients have a very increased risk of cardiovascular disease for a whole milieu of reasons. And so basically the cardiac diet is appropriate for our patients, limiting saturated and trans fat, and there is research indicating that 3 to 4 grams of omega-3 fatty acids or 2 servings a week of fatty fish may improve triglycerides and cholesterol, specifically in this population. We know that our patients have a higher risk of malignancies because we've suppressed their immune system, and thus they aren't as able to fight off things that are foreign in their bodies. So certainly those fruits and vegetables, the antioxidant-rich foods, give them more tools to hopefully prevent malignancies or cancers. And we know specifically that our patients are very at risk for skin cancer, and they're often advised to avoid the sun, and so that may mean an increased need for supplemental vitamin D. Now, speaking of calcium and vitamin D, this is pretty big for our population. Not only have our patients done pre-existing bone damage from being a CKD and or dialysis patient, but now we've put them on medications that will further damage their bones. And in fact, in the first 6 months after transplant, they continue to do significant bone damage, and that really doesn't level out until about 3 years after transplant. And this is significant for our population, knowing that 90% of our bone mass accrual happens in the first 20 years of life. This may additionally be a risk factor for cardiovascular disease, as we have calcium losses and thus more available for calcification. And so we want to continue to recommend enough but not excessive amounts of calcium. A Canadian study showed that our patients' vitamin D levels were actually pretty comparable to the general population, but both populations are very vitamin D deficient, and it's just an extra big deal for our patients who already have compromised bone health. So some specific concerns that I wanted to address are, we touched on elevated PTH and hypophosphatemia, and this is very common. We know that our patients, again, because of poor phosphate control, tend to enlarge their parathyroid. And just because that patient now has a healthy kidney doesn't mean that their parathyroid stops working overtime. That parathyroid is still hypersecreting, and this now functioning kidney is getting rid of phosphorus quickly. So in an ideal world, we would modulate this with diet. However, many of our patients typically need phosphate supplements. In fact, about 85% percent of our patients have early hypophosphatemia, and 69% of our patients have elevated PTH levels at the time of transplant, but that number is only down to 47% a year later. 45% of our patients needed phosphorus supplements in the first 6 months after transplant. Hyperkalemia is a risk, certainly because of medication. So initially after transplant when they're on higher doses, or if they have a rejection episode that we're trying to treat them for, they are going to be at risk for needing to control their potassium intake. Hypomagnesemia is common. Again, it's a medication side effect, the greater kidney excretion. This, interestingly, is a risk for acidosis, and that is a concern with our patients. We know that acidosis accelerates the progression of chronic kidney disease, and that compromised kidney and impairs growth. So, and again, in an ideal world, we'd encourage high magnesium foods, but many of our patients end up needing supplements. A need for very tight sodium control, especially at first, because of the 80% of our patients have elevated blood pressure after transplant. And again, it's dependent on medication dosing. Now, the one caveat to this is we rarely transplant infants, but our toddlers, if they're not on an oral diet, potentially could need some sodium supplementation to reach DRI because we give them adult-sized kidneys. Our patients do have a 2.6% risk of post-transplant diabetes. This is often related to weight, so we want to encourage weight maintenance and a healthy weight. Sometimes this is just a medication side effect. I remember having a very thin young man who developed this as a medication complication, but regardless of the source, limiting sugar intake, especially sweetened beverages, seem to be a very potent modulator of this. Is very important. Our next slide is going to talk about declining kidney function, as unfortunately we know that unfortunately our kidney transplant doesn't last forever. We actually, because the science and technology isn't there, we have to use medications that potentially damage the kidney. So that kidney may last 10, 15 years, hopefully longer, but a lot of that is dependent on how well our patients do with some of these lifestyle measures. Obviously, some kids can get an infection and it's nothing they can do, but we are a big part of helping ensure the longevity of that kidney, hopefully. We need to, I feel that we need to know what our patient's GFR is, or approximately, and be working with the transplant team so that we can anticipate some of these changes and potentially even be educating our patients and families to be prepared for some of these nutritional challenges that are going to happen as that kidney eventually does fail, not immediately post-transplant, but as that transplant starts to fail. And certainly we need to watch for PTH levels, and then we go back to guidelines that we would consider for CKD, that phosphorus restrictions are needed when the PTH is elevated, and that cuts to 80% of the DRI when we start seeing elevated phosphorus levels as well. Because this often ends up limiting dairy products, we need to be considerate of calcium and vitamin D supplementation to hopefully maintain as much bone health as we can. Now, we know that our food supply is pretty atrocious for phosphate additives in processed foods, and really there's evidence even in our healthy population that phosphate isn't good for cardiac health long term. So really we should be encouraging our patients to limit phosphorus from processed foods throughout the CKD milieu, including transplant. Protein limitation may be necessary as that BUN is increasing as they further down that CKD spectrum, and growth and adequacy of intake start to be concerns again as they become more uremic. Our next slide is going to be talking about fluid, and I think that this is a topic that really needs some special consideration, because I feel that we need to be treating fluid just like we would a medication. Obviously, our patients have to be adherent to their medication and their medication timing, but that transplanted kidney is not going to have the same hormonal milieu as a native kidney, and so we need to be advising our patients that they have to be perfusing that kidney. Now, we know that our youngest of patients get adult-sized kidneys so that it will last them longer and give them full kidney capacity. And so the guidelines are 2,500 milliliters per amount of body surface area, and again, a possible sodium supplementation if needed. Our older children and adolescents typically need about 1.5 to 4 liters a day. That, you know, a 25-kilogram kiddo may need more like 1.5 liters of fluid, but your larger, your 80, 100 kilogram adolescent certainly needs more, and a guideline might be that 1 ounce per kilogram, especially for some of our larger adolescents. We really want to push sugar and caffeine-free beverages, and I get the question all the time, well, what about diet products? And I know those are very controversial. We know that some may change our gut flora. They're not a completely benign substance, but I always look at what the immediate concern, the most acute concern is. And I know that sugary beverages are going to have a lot more immediate impacts on a transplant kidney. So although I'd rather have them drink milk and water and healthy choices, I'd prefer an artificial sweetener over a sugary beverage. And although caffeinated drinks do have fluid in them, they also have mild diuretic effects, so those at least should be limited. I think we need to talk about some ideas about fluid intake to help work with our patients. Many of our patients go into kidney transplant with a G-tube, and I say if you have a CKD patient on the cusp, push for that feeding tube because it's going to help them get the very high fluid needs. We're talking some of these toddlers need 45, 50, 60 ounces of fluid, and that's not a normal natural intake for a toddler. And until they get used to drinking that much, we need to find alternate ways to get that fluid in them. One thing that we can encourage our patients to do is encourage a cup of fluid before each meal and snack and with meals. This may help modulate appetite because weight gain is such a concern for our patients. Water bottles give our patients a tool to be able to track how much water they're drinking, and maybe something we can easily use with the school. We have a very technology apt generation, so if we can incorporate technology via phones or alarms or apps. There's all sorts of water drinking apps out there that may be fun for our kids. Flavorings, if necessary, if they say that water is too boring, and adding fruits, adding some berries to a cup of water may be a way to make that kiddo think it's more fun. And again, I can't emphasize enough, treating fluid like a medication. It is their duty to modulate that or perfuse that kidney. Now we're going to touch very briefly on transplant medications. We know that there are a lot of risks for transplant medications, and these that I've listed here are just the ones related to nutrition. I'm not even going to talk about the nephrotoxicity of some of these medications or the fact that they enlarge your gums or make you grow hair in weird places or lose hair in weird places. These are just the ones that I think we have to be particularly aware of as a dietitian. And although we may not need to know the nitty-gritty of the doses that these kids are on, I think it's important to be familiar with transplant medications, including other medications that our patients are on to treat some of the side effects associated with transplant, so that we can be looking and being a communicator to our team, because we're the ones talking to them about their diet, and we may be the ones able to tell the transplant team if there's some sort of a nutrition issue that the team needs to be aware of that might be related to one of the medications, so they can potentially modulate that medication if it's appropriate. And if you ever have a symptom that you're concerned about and a medication that you're unfamiliar with, check it out. There's a nice table here, and we don't have time to go through each of these, but all I can say is that I am always excited when the docs are able to get the kiddos on the smallest amount of steroids as possible, because we know there are just a ton of side effects with those, and unfortunately steroids are a necessary evil. Most of our patients need at least a small dose, and hopefully these side effects are pretty minimal when they're on the smallest dose, and hopefully we don't have too many rejection episodes to treat that we need higher doses of these. But you can see here, Prograf, again, a major issue being elevated potassium levels, low magnesium, especially some of these induction agents or medications that they use early in the transplant process or to treat a rejection have sometimes GI side effects that we need to be aware of. Moving on to drug-nutrient interactions. Now, what this looks like in our world is these are interactions that involve stimulating the immune system or affecting the ability of the medication to enter or exit the body. And because so many of our medications, over half of medications use this cytochrome P450 pathway that's found in the intestines and liver. That's the same pathway that our food is often processed through. We run risks for drug nutrient and drug botanical interactions. Now, the well-established interaction is grapefruit juice. It interacts with several medications. I've listed just a few here, a couple transplant rejection specific medications, and then statins and calcium channel blockers for blood pressure that many of our patients are on as well. So I think the take home here is we need to even be aware of beverages that could have some grapefruit juice in them. For example, Fresca is something I always advise my patients on. It's a drink that they may sometimes consume. Now, there is some research that pomegranate and the juices and Seville oranges, that very bitter orange, may have similar toxicity, but not to the same extent. So certainly we just need to be advising our patients on moderation and to be looking for those foods if there is a concern. Interestingly, at that NATCO meeting I attended, they shared that clementines have a similar effect, and the advice given was that adults should not eat more than 6 clementines in a sitting and children 3. So I thought that was interesting, as that's more of a kid-friendly food. There is actually research in California, red wine, that can have an interaction with cyclosporin, and our kids probably aren't drinking wine, but they could be doing grape juice or grapes, and so there's no definitive evidence, but that one's a red flag in excess. Some of these other, certainly I want my kids to be eating healthy foods like cauliflower and broccoli, but just really as with any food, I want things in moderation. I don't want a plate of broccoli because there is some biochemical data, even though not direct studies, that these could be issues. Again, vitamin C, good, but do I want my patients on vitamin C supplements? Probably not, because they potentially can have an immune suppressing response. Sirolimus can sometimes be controversial, whether to have patients eat or not. My facility always advised, if you're going to eat, always eat. If you don't eat, never eat, to keep those levels consistent. Moving on now to herbs and complementary medicine, a 2001 study showed that 30 to 40% of Americans use herbal products regularly. And a 1997 study, but I think it's still very relevant, 323 adults of either post-transplant patients or patients waiting for a kidney transplant use these products as well. And these could vary anything from a specific vitamin that they were taking to some pretty heavy dose herbs that they were trying to use to modulate an organ. So what's interesting, the research that they did on this, when asked, they were given a survey, and when asked if they communicated with their healthcare provider about it, many people left that question blank. So I think we need to make an environment where people feel comfortable to talk to us about this, and perhaps hopefully be open to their thoughts. And if we do the research and it's something that might be okay, maybe that's something we can compromise on, so that we don't turn off people who these sorts of things are important to, but we need to be very aware of what the risks are. St. John's wort is well established that people have lost transplants because of using St. John's wort, but there may be things beyond this as well. Interestingly, I mentioned fish oils earlier in the talk, and these may increase sirolimus levels. It's not necessarily a contraindication, but we need to know if our patients are on fish oil supplements and sirolimus, so it can be managed by our transplant coordinators. Now, the herbs that I've listed here, the ones that I've starred, there's either been a case report or a small study that shows a direct impact with these herbs and medications, whether it be anti-rejection medications or other medications that our patients commonly take. Some of the other ones are just biochemical or data that's theoretical, but something maybe we should at least be aware of. And certainly if we're wanting to know about a certain herb, we can look at the National Center for Complementary and Alternatives Medicine's website. Now, moving on to transplant growth, certainly some of our patients, probably because of the medications they're on, may continue with poor appetite and poor weight gain, and we need to be aware of that end of the spectrum. But typically, our patients gain weight, and in fact, obesity rates double in that first year after transplant, especially in the first 3 to 6 months. And we need to prepare our families for this. We need to create an environment that it's not that these kids don't have self-control or they're doing something wrong. It's a known effect of transplant, and so we need to prepare, again, doing some pre-teaching. Metabolic syndrome is present in 38% of our adolescents, and we need to really stress the importance of physical activity. NAPRTEX data says that our patients, more so than the general population, as CKD patients are very inactive, typically about half of the number of the healthy population, but this number does not increase after transplant. We need to try and figure out why. Now, some sports are limited because we don't want contact sports for risking that solitary kidney, but there are certainly things our kids can do to be active, and we need to be developing a plan perhaps even before transplant takes place. Linear growth, often having a transplanted kidney will improve this, so often we wait about a year before starting growth hormone. However, many of our patients, because they were so very short to start with or continue to have some impairment in that area, do need growth hormone for catch-up, and there's actually some data saying that growth hormone can improve or promote osteoblast activity, potentially improving bone health. Now, KDOQI guidelines say we need to be assessing these patients at least every 6 months and at least every 3 months for younger than 3 years of age. However, I would be an advocate that we need to be meeting with our patients. I met with my patients as often as they came to transplant clinic, even though that was a lot at first, because that's when we're seeing the most nutritional implications, the weight gain, etc. So moving on to weight management on the next slide, I am just jumping ahead because I apologize for some of these slide transition delays, but we need to be talking about weight management with our patients, and I think that it's important that, again, we work with them, preparing them before transplant for what to expect. We need to be reviewing growth charts frequently and discussing clinically. Again, it's not a blame game with our kids. We need to discuss it from a data standpoint and what we can be doing to modulate this risk factor. Again, planning access to physical activity, and again, working on lifestyle changes with weight maintenance or slow weight loss. Ideally, our patients should not be losing more than 1 to 2 pounds a week, and really ideally, if some of these kids have room to grow, hopefully they can grow into the weight with their height. Now, weight loss and weight management is so psychologically based. It's so much more than calories in and out that I feel we need to be working with our patients on issues such as sleep. Many of our patients have a lot of reasons to have poor sleep habits, and a 2008 meta-analysis of adults and children and the general population that I think is very applicable to our population showed a 0.35 increase in BMI with each hour short of sleep. Stress and depression management, certainly that emotional eating is a role. There's plenty of data showing that self-monitoring when the patient's involved in setting those goals and creating SMART goals, specific, measurable, time-bound, is very important. They shouldn't be our goals, they need to be the patient's. I've had lots of patients or families say that they don't want to punish the siblings by putting them on a diet too. Well, I don't feel that putting siblings on a regimen of physical activity and fruit and vegetable intake and a heart-healthy diet is going to be hurting anybody. In fact, it may prevent chronic disease later on. And so certainly making sure that the family is on the same healthy diet that these kids are, and group programs such as TOPS, Weight Watchers, have been shown to be effective in providing the support that's needed. Now, screen time, we know that more than 2 hours of screen time a day is associated with obesity in the general population, and it certainly is as well in our CKD and transplant population. 98% of our patients exceed the AAP screen time guidelines, but what's interesting, I feel, is that it's also a risk factor for progression of CKD. And I'm finally going to talk about nutrition here at the end. Simple changes, lifestyle changes of limiting simple carbohydrates, saturated fats, using water to our benefit to perfuse that kidney, hopefully to blunt appetite. We're going to go through these next few slides on food safety a little more quickly, because I'm going to share a reference with you at the end that hopefully will be valuable. We know that our patients have impaired immune function, which puts them more at risk for foodborne illnesses. And we know from the CDC that of the 48 million people who develop foodborne illness, 128,000 are hospitals and 3,000 died. These are our transplant patients because they're immunosuppressed. They're the group at risk for increased hospitalization and death. And certainly graft function, if for no other reason than vomiting and diarrhea, dehydrate that and impair that kidney. So we need to tell our families the risks to be aware of. Ideally, if there's a food they suspect, they would save that food and freeze it and hopefully help prevent outbreaks in other people. So again, food safety is a very broad topic, but I've listed here some of the things I think we really need to make our families aware of, making sure they know the food danger zone. Simple things like cutting board safety, that sell by or use by dates are the ones we're really looking at as opposed to best by. Those are quality issues. I know many families who will throw a half-eaten plate of food in the refrigerator for a child or a sibling to eat later, and that's just because that grows bacteria. That is not a good practice in our patient population. That if it's hot outside, those temperature guidelines cut to 1 hour, that we're not wanting food to sit out more than. And then leftovers, some of these are a little more stringent than I think people realize. Leftovers, typically a leftover with meat in it, it's 3 to 4 days maximum that you can eat it leftover. But even foods like bacon or processed meat really shouldn't be in the refrigerator more than 7 days. Even things like eggs should not be more than 2 weeks. So knowing some of those guidelines and teaching our families some specifics on those leftover guidelines. Listeriosis, I was not a very popular person when I told my patients that they probably shouldn't be eating a cold deli meat sandwich again, that really they should consider hot sandwiches so that meat was heated and thus cutting the risk of listeriosis. Certainly the organic craze with unpasteurized foods such as raw milk, honey, those are absolutely not appropriate for our patients. And using caution with things like sushi, egg products, certainly buying pasteurized products of those. The Partnership for Food Safety Education does this website that I'm going to be showing on the next slide, but I think most dietitians are pretty well aware of the core 4 practices, so I'm not going to discuss these in depth, but a couple tips that I picked up is that ideally we should encourage our patients to use paper towels to wash countertops. If they're using wash rags, they just need to be laundered in hot water very frequently. Another tip I thought that was interesting was to grab some extra produce bags from the produce section to bag up meat when you pick it up, because sometimes meat leaks and then that contaminates the rest of our food even when we're grocery shopping. Teaching our patients the importance of getting a meat thermometer, that yes, it is important to know internal temperatures. On this next slide, I included this web reference so that you would have it. This is something that Partnership for Food Safety, which includes the USDA, has developed specifically for transplant patients. So there's no need to reinvent the wheel. Granted, this is probably a little more adult focused, but this was created specifically for our population. So a handy, already made website that's available on the internet, and European research study indicated that there's a lot of inconsistency about the food safety information we're giving our patients, if we're even giving any at all. And so this may help standardize that information, and it also has phone and web resources for patients to contact. We're just going to touch on this last slide before I turn things over to Leah, who has really looked into the CMS issues a lot, so I think you'll get some valuable information from her. We're going to talk about formula use in our transplant patients. If our patients were on a renal formula before transplant, sometimes this is still needed until that kidney function picks up. A pediatric formula like a Pediatric is probably appropriate once that kidney is functioning until they're able to get on an oral diet. Article looked at 5 different studies and transition time for our youngest of patients to be able to get on an oral diet, and typically it's within about 6 months. However, there are outliers, primarily kids who had severe oral or texture aversions, and what dialysis and CKD dietitians can be doing is getting them involved with OT or speech therapy ahead of time. Even if they don't make much progress, it really sets up the stage for them to be able to move to an oral diet more quickly after transplant. Again, water flushes and boluses may be needed after 2 feedings to meet fluid guidelines, and as that transplant function declines, we may need to start looking at electrolyte modifications again, and certainly using blends such as Renal or a Saplena, something like that with a pediatric formula can possibly, hopefully, modulate some of those electrolyte issues to use as a bridge to get to when they need a transplant again, or unfortunately going back on dialysis. So I am ready to turn things over to Leah.
Thank you, Chris, for that overview. That was very nice. So the rest of the presentation today, I'm just going to speak a little bit about the nutrition requirements from Centers for Medicaid and Medicare, also known as CMS, and what's listed in their guidelines for surveys and procedures. The Center for CMS and the Department of Health and Human Services puts out interpretive guidelines for transplant centers to follow to help meet the requirements to be CMS accredited. So at the bottom of this page, you can see a link which takes you to the interpretive guidelines, which this information today has been pulled together to go through what the nutrition requirements are within that guideline. So the topics that we're going to cover today are policies and procedures related to dietitians working in transplant, and then the dietitian credentials and education requirements as listed by the guidelines, and then what the involvement should be for CMS for nutrition throughout the phases of transplant. We're also going to talk about quality assessment and performance improvement, because per CMS that is something that dietitians and all of the disciplinary teams should be involved in, and then touch a little bit on the dietitian role with living donors. The policies and procedures related to dietitians start with just saying that the multidisciplinary team includes a dietitian, so that every transplant patient and every transplant center should have a dietitian as a part of their multidisciplinary team. This team should be coordinated by a physician. If you work in transplant, you will also know that there is social work and pharmacy and financial coordinators, as well as transplant coordinators and the transplant surgeon and the medical or physician following the transplant patient. The written policies and procedures for the center need just to define the roles and responsibilities of all team members, which does include a dietitian as well. The roles need to be defined on who's going to do what, and the responsibilities as well as the education requirements and the documentation requirements. So CMS does not dictate in their interpretive guidelines what these policies and procedures are, just that they are in place and they define these different things. One of the things, if you have a surveyor come, they may ask, what, as a dietitian, what are your responsibilities for the transplant team? What kind of education are you receiving? They want to make sure that you are doing the things that are listed in these policies and procedures. And then as a whole, the medical record provides information to show that you are meeting the written policies and procedures that your institution has put in place. One thing I forgot to mention before is as we go through, you'll see little parentheses with X's and then numbers behind it. If you have the interpretive guidelines from CMS with you, or if you print them, these are the tag numbers that these different topics have come from. So that's just a reference for you to look at if you're looking at the interpretive guidelines. For dietitians seeing transplant patient, the requirements are that the dietitian is CDR certified, and that where state licensure applies, so in the states where it's required for a dietitian practicing to have a license, that they also have state licensure. If you have a center that is located in more than one state, then you should have licensure in all of those states if it's required by law. Another thing that surveyors will, which is I think is a best practice from my experience, is also when you renew your licensure for the state or CDR, that you have it printed at the time you renew, and that there's a date put on it at that time and initialed, so that when the surveyor comes in, they are aware that it was renewed prior to expiring the previous year. Another thing that is required by CMS is that there is a job description for dietitians that outlines transplant-specific nutrition care and the training requirements. The recommendation doesn't go any more than that to say what is in the job description, other than that it's transplant-specific and it has training requirements listed for dietitians. There are requirements listed in CMS interpretive guidelines for nursing staff, which their documentation should include an orientation of their policies and procedures, structured education, and then an ongoing education and evaluation of their knowledge. But that is not listed specifically for dietitians. It would probably be a good idea to have those things listed in any training requirements you have for dietitians working in transplant as well, because it could be something that surveyors look for. The only thing specific to nutrition and dietitians working in transplant is that they have a comprehensive and ongoing transplant-specific training, and it just lists that this may include new technology, changes in the field of transplant, best practices, any research, conference updates on information. So what they're looking for is that the dietitians have ongoing education and they're keeping up to date with the most recent information. So the paper that Chris mentioned at the beginning that's hot off the press, that would be a good thing to read and see what's recommended in there, and then just including that into your training, anything that's listed there, making sure that that is something that you are doing in your center. That could be a reference if you wanted to use it. So CMS does want dietitians involved through all of the phases of transplant. They are looking to make sure that there is documentation of nutrition assessment and interventions, just to ensure that the nutrition needs of the patients and the candidates are being met. So again, they don't specify what that is, just that there is a policy in place and that it is documented the way that your policies have written it. The pre-transplant phase, or the evaluation phase, which is defined as the time from the first presentation for the evaluation for transplant until the patient enters the OR for surgery. They list that they want the dietitian to be and the team to be looking at suitability for transplant, and then the selection criteria, looking at the patients, are they ready for transplant, where do we need to get them to transplant, and then that the criteria we're using is fair and non-discriminatory across candidates. They also want to see that there's education done with families and patients to make sure that they are aware of the needs post-transplant, and this wouldn't be a surprise at the time, so they are educated on the post-transplant needs. So we, in our pre-transplant evaluations in my center, we do go through what to expect following the transplant, and we put that in our documentation as well. The transplant inpatient stay is the next phase that is defined by CMS, and this is a definition of per CMS of the time the patient enters the OR for the surgery until the time that they're discharged from that hospital admission. During this time, CMS states they want a nutrition assessment, and that there's discharge planning going on. Discharge planning, which has another definition from CMS, is just any time during the time from the time the transplant recipient wakes up from their surgery until they are discharged from that inpatient stay. And they're looking to make sure that there is a discharge plan. So what are we doing to say that they're ready to be discharged from the hospital, and also any follow-up after they leave the hospital for transplant-related nutrition care. Also that we're providing a transplant nutrition education during that admission, and that we are coordinated to care for any other services they may need. So if you have a patient or a child that is tube fed, we're looking at getting their formula set up and their feeding tube supplies. Also, if there are other services they may need once they leave the hospital or during that stay, such as OT or speech therapy or physical therapy. And again, the nutrition piece of it, they want to make sure we're addressing, but also as a whole team, all of the needs are being met. The third phase, as defined by CMS, is post-transplant care after they are discharged from the hospital. And per the interpretive guidelines, CMS surveyors do not usually or commonly attend and review outpatient clinics visits after the transplant surgery admission, except to ask recipients about their inpatient experience and discharge planning instructions to look and make sure that the things that were needing to be addressed at the time of discharge were being addressed. This doesn't mean that dietitians don't necessarily no longer need to see the patient. In some cases that may be true, but they want to make sure that we have a process in place to look at what's happening with the patient and meet their needs, and have a place to refer patients back, a process in place to refer patients back if there is, in fact, a need for nutrition intervention later on. The other thing is they also want to make sure that the policies and procedures are being followed at this phase as well. So anything that's written in your documentation for your policies and procedures for nutrition involvement, that we're following that, and that we do have the process outlined on how to refer back to nutrition, or that what is the follow-up after transplant care. In our institution for kidney transplants, we see them every time they come to their clinic visits. It doesn't have to be that way, but that's the way it's written for us, so we have to follow that because it is written in our guidelines that way. Another area, so quality assessment and performance improvement. This is also the post-transplant area, QAPI. CMS does want all of the team members, including the dietitian, to be involved in quality assessment and performance improvement. They would like them to be identified in written policies and procedures by title and what is their role and responsibility for the QAPI. They want to make sure that there's ongoing and comprehensive quality assessment and performance improvement that includes all of the services offered by the transplant program. So we're monitoring all of the program services we offer, and we are monitoring for improvement. Where can we make changes to make this better for our patients and their families? This also should include all of the phases of transplant. Also, that anything that's discovered during this quality assessment and performance improvement, that the information is given both up through the hospital chain up and then also down, so that staff can learn and improve the care of patients and families. The last piece I'm going to touch on today is just about living donors. Living donors must also be provided nutrition services by a qualified dietitian that has the same credentials as transplant recipients. The level of need may vary depending on where the nutritional status of the donor is. Just that they want to make sure that there's, again, policies and procedures put in place by your institution that meet the needs of the donors and specify what the intervention will be of the dietitian for the living donors. There also should be appropriate documentation following these policies and procedures. Services can be phased out if there is no need found during the evaluation, just as long as there is a process to reinitiate nutrition involvement if something is noted later on. And then also for, as Chris talked about, making sure there's education of the living donors, making sure they're educated about the post-donation discharge nutrition plan, making sure they're aware of the nutrition needs post-transplant is also something that should be covered. So again, it is up to your institution on what level that the dietitian would be involved for assessment, counseling, and intervention, and that your policies and procedures just follow what you've written you said you will do. So with CMS, every time I see them, I feel like something has changed, and this is pretty common with them because they're always looking for best practices that are out there and new research that's out there, and then also the things they see happening in other centers they're going to make sure that patients are receiving the best care that they can, and we're following the standards of care set throughout the all transplant centers, and everyone is kind of at the same level getting a good standard of care. So when I have questions, this is where I email. I send questions to this email address, the scg_transplant@cms.hhs.gov. So that is somewhere that if you have questions about knowing what you're doing, is this the right thing to do? Am I meeting the guidelines? Am I doing what I need to do? You can always reach out to CMS. Local, so state and regional CMS could be under contract. So the surveyors that come to you are potential to change in different contract companies. They're contracted out. This is the national reference or the national center for CMS, and so they have they're constantly there and able to provide answers as from a national level perspective. So that is all that I have for today. Thank you guys all for coming and listening with us today.
Thank you, Christina and Leah, for an excellent presentation. It was very, very informative. We are running a little bit over time, but we do want to provide our audience with the opportunity to ask questions. So if there are any questions out there, please use the questions pane to the right side on the control panel to type in your question for our speakers. While we're awaiting questions, I just want to remind everyone that your CE certificate is available for download, again, under the Handouts tab on the control panel to your right. We have one question. The question is, for living donors, what upper limit for protein do you advise long-term post-nephrectomy?
Well, DRI would be optimal. Unfortunately, there's just not great data on this, so I think we just have to look for excesses in the diet and try to counsel those individually. Leah, would you have anything to add?
No, that would be my recommendation as well, the DRI, because we know that's what they need, and not to exceed that, because we know in some cases excess protein can cause some issues with kidney function, and there's more work for the kidney.
Thank you. We have another question from Michelle. Can a dietetic intern complete an assessment as long as the RD signs off on the note for CMS guidelines?
It's a good question. So can a dietetic intern complete an assessment? My understanding from CMS is they want somebody educated and knowledgeable about seeing patients prior to, so they have completed the competencies and able to sign off. I think that's a good question that I would reach out to the CMS guideline and email them and ask specifically if that's okay. My personal preference would be to not have them do it alone, but have me do it with them. So yes. So I think that's a question I would ask. I don't really know that I can say whether that would be okay or not. I think you'd have to ask the CMS office on that.
If I could add on to what Leah said, this actually was a question that was brought up at the NATCO meeting that I was just at, and they said as long as the dietitian is supervising and is reviewing the chart notes and co-signing, being very diligent about that, it is in theory okay, but I think I would side with Leah that it's an area that for sure the dietitian probably should be in the room to fill in any gap, and it's something to probably ask your individual surveyor, and something that probably a little easier done yourself.
And we'll take one final question. Is there any information regarding improved nutrition-related quality of life post-transplant?
No, there's none that I know of, and there may be some data. The C-KID study that's ongoing is publishing information all the time. They've certainly looked at quality of life for dialysis patients and pre-transplant. I think most patients self-report that, and this is just from my clinical experience. But Leah, are you aware of any published data?
I'm thinking, and I'm not aware of any at the moment that I can think of that specifically show transplant, post-transplant quality of life related to nutrition improvements. But anecdotally, I mean, patients that I see all the time, it's much easier for them to live a normal life. Nutrition, speaking about quality of life from a nutrition perspective, they don't have all the restrictions. They can eat the same things that their friends are eating it's a more normal diet for a lot of them when they're getting, as opposed to the advanced stages of CKD and then on dialysis.
The caveat I would add is I've actually had patients say to me within those first few months after transplant that it's a lot harder than they thought. I think especially because sometimes there's new restrictions like limiting sugar more tightly and whatnot, that especially immediately transplant, we need to be not setting up our patients to assume that it's just going to be a walk in the park.
Excellent, thank you. I would like to thank again Leah Laudatan and Christina Nelms for the excellent presentation today, and of course to our audience for joining us and for your participation. On behalf of VIA, VitaFlow in association with you, we hope that you found this information valuable to your practice, and have a good rest of the day.